begin with the end in mind. So begin with the end in mind. What's the end in mind? Because I don't think many people want to start a medication, and the end is that I'm just going to be on this medication for the rest of my life and be dependent on this medication for the rest of my life. So if you're, looking at providers or interviewing providers that are looking at prescribing this medication, then you got to get a sense of what is the end game here. And in my mind, the end game should be medication use, usually less than a year, measured in a period of months. Because a more profit-driven approach would be, we want to get you on this medicine and keep you on this medicine for the rest of your life, because then you're going to be a customer for life. So I think people that are looking at different options for these medications need to begin with the end in mind.
Hey there, and welcome back to the Reshape Your Health podcast. I'm your host, Dr. Morgan Nolte, and I cannot tell you how thrilled I am to have this conversation today. I think it's going to be one of the more popular episodes that I've ever done because it's on a hot topic of weight loss medications. My guest today is Dr. Paul Kolodzik, and he is a board-certified physician both by the American Board of Preventive Medicine and the American Board of Emergency Physicians. In a 30-year emergency room career, he has witnessed firsthand the failures of mainstream diets and the medical system overall, which prioritizes medications and surgery over diet and lifestyle changes to prevent and reverse disease. And if you've listened to me for any length of time, you know that is right up my alley. And I was so excited to hear someone equally passionate about disease prevention. And in his metabolic practice, Dr. Kolodzik uses the technology of continuous glucose monitoring to help his patients achieve weight loss and improved health. He also has integrated the prudent use of new weight loss medications into his practice, and that is what we're talking about today. Semaglutide, Wegovy, we're going to talk about all of the most asked questions that I've been seeing online. In his recently published book, The Continuous Glucose Monitoring Revolution, Dr. Kolodzik presents a comprehensive program for metabolic health success using CGMs and limited use of weight loss medications. I already know our philosophies are going to be so well aligned. Dr. Paul, thank you for coming on this show.
Thank you for having me, Morgan.
Yes. Well, let's get started just with, semaglutide is the, you said generic form, right, of the medication.
Yeah.
How does it even work? Let's start there.
Okay. So just to get kind of the name straight, semaglutide is the generic term for Ozempic and Wegovy. They're all the exact same medicines. And then on the other side, made by Lilly, is Mounjaro, which people have heard of, which is the exact same medicine as Zepbound, which is the weight loss branding, but they're the exact same medicine, and the generic for that is tirzepatide, just so people kind of know the terms of this. So these medications, as you probably know, were originally used for diabetics because they had a special quality where they control blood sugar, but they don't cause hypoglycemia. So the pharmaceutical firm Novo Nordisk initially realized that the diabetics on this medication were losing weight. And so they thought, well, it doesn't cause hypoglycemia. Let's go back and do some studies on patients that are not diabetic but are overweight. And the same thing happened. Patients lost between 14 and 17% of their body weight during those studies. So then they went ahead and got them approved as FDA medication. So that's kind of the history of these medications. You asked how they work. They basically have three mechanisms of action. The first is that they slow gastric emptying. That's a fancy way of saying your stomach stays fuller longer. There's a valve between the stomach and the intestines called the pyloric valve, and it narrows that valve, so your stomach's going to stay fuller longer. The second mechanism of action is that it lowers blood sugar, just like we talked about. And this is kind of what my practice has been built on to some degree for the last 7 years. If you lower blood sugar, blood sugars are high in America in general because of excessive carbohydrate intake, the issue of insulin resistance. So the focus of low carb and intermittent fasting historically is to lower blood sugar, and then the organs in your body, let's say your muscles, start looking around for another source of energy, and that other source of energy is often the fat that is deposited around our middles. And so that's the other method, the second mechanism of action of these medicines. They lower blood sugar, so you essentially burn more fat. Does the same thing to some degree as a low carb approach and intermittent fasting. And then the third is they have a direct effect in the brain in the hunger center, the hypothalamus of the brain, to suppress hunger. And so those are the three ways these medications work. And, as you're aware, they've been fairly effective at helping people lose weight with those three mechanisms.
And specifically with the effect on the brain, is that they're a GLP-1 agonist?
Yeah. So
Okay.
basically, they are. That's a great point. I didn't bring it up. So GLP stands for glucagon-like peptide. So these substances are mimicking a natural hormone that, for example, helps suppress hunger. So it's basically an analog or a mimic of natural hormones in the body. So they kind of take over and accelerate the effect of the natural hormone.
And what things I know that like protein, maybe fiber, maybe water can stimulate GLP-1 like these medications do, but what natural things aside from these medications can help stimulate that GLP?
Yeah, you know what one of the main one is, and I being an advocate of low carb diets, low carb diets have a tendency to be higher fat diets. So,
Mhm.
you focus on low carb, generally higher protein, but low carb diets are generally higher in fat. And one of the biggest GLP-1 stimulants is fat. And so when I have my patients, I'm not insensitive to cholesterol issues, but when I have my patients want to work on suppressing hunger, we go low carb and higher fat. Think
Mhm.
about it. You can only eat so much steak, but you can eat bag of chip after bag of chips. So I think fat is an important component of a low carb diet, and fat is one of the macronutrients that stimulates GLP-1.
Okay, awesome. I just wanted to point that out that you can get a similar satiety effect by kind of changing your macronutrients up a little bit. I'm gonna
Absolutely.
I'm gonna ask the elephant in the room question, and this was one that I asked you offline. Is this okay for me to ask? I want you to explain the profit motive behind these weight loss medications and how people can differentiate if this is a profit driven business trying to sell you a medication to make a lot of money versus if this is an ethical practice that is using medication wisely as part of a more comprehensive plan of care.
Yeah, so I would ask right from the beginning, and I stole this term from Stephen Covey, The 7 Habits of Highly Effective People, is begin with the end in mind. So begin with the end in mind. What's the end in mind? Because I don't think many people want to start a medication, and the end is that I'm just going to be on this medication for the rest of my life and be dependent on this medication for the rest of my life. So if you're, looking at providers or interviewing providers that are looking at prescribing this medication, then you got to get a sense of what is the end game here. And in my mind, the end game should be medication use, usually less than a year, measured in a period of months. Because a more profit-driven approach would be, we want to get you on this medicine and keep you on this medicine for the rest of your life, because then you're going to be a customer for life. So I think people that are looking at different options for these medications need to begin with the end in mind. And then that usually drills down to, what sense do you have that the provider wants to eventually get you off the medicine? And that is reflected in what are the support services that you're going to be provided? Is there going to be nutritional counseling? Is there going to be a structure and support for whatever your workout regimen is? And, as you and I talk, I've been doing this well before these medications came out in terms of focusing on reversing insulin resistance, which is, the primary approach to helping people, middle-aged, overweight Americans lose weight. And so, I believe that program necessarily includes a low-carb approach, intermittent fasting, and strength training, because strength training also decreases insulin resistance. And coincidentally, you lose muscle mass on these medications. So strength training is a critical aspect of that. So, try and get a sense of what the end game is, and then get a good sense of what your support services are doing.
Mhm. And so you said that compounded medications are different than the brand name medications on like the profit margin for physicians. Will you just kind of explain that a little bit too?
Yeah. So when docs write a prescription, generally there's no kind of kickback, at least not that I'm aware of. So that's a good thing that I'm not aware of that. So if you get a prescription for Ozempic or Wegovy or whatever, obviously, there's other entities that have stakes in that game. The pharmaceutical distributors and the pharmaceutical company. If it's a compounded medicine, in compounded medicine, it's not exactly a generic, but you can think of it as a generic. Compounded medicines are the alternative non-brand name medicines. And they can be provided through providers, and I, in fact, do that myself, provide it to patients, and they're generally at a lower cost. This is allowed at this time because there's a shortage of, for example, Wegovy and Zepbound. I don't know if it's going to continue indefinitely, but providers that supply these medications will have some kind of margin built into that. I would like to see a majority of that margin go into these support services that we talked about, and not just a pure profit motive. And I'm trying to draw a contrast again between a private practice like mine, and just getting on the internet and getting somebody to send you medicine without any support, and maybe even hopeful that you're going to be, a lifetime client of theirs.
Yes. Before this interview, I was Googling something about semaglutide, and it essentially popped up all of these sponsored ads on like just
Yeah.
$99 a month or 139 a month. And it's like
Yeah.
those types of ads probably indicate that this is somebody who just wants to prescribe you the medication and not necessarily provide the support services necessary to help you successfully like wean off of the medication. And there's so many questions that I want to ask, and I definitely will. We did a good job preparing for this episode, but let's kind of talk about the next logical question, which what are the out-of-pocket expenses that you're seeing for your patients right now? And, is this covered by insurance at this point in
Right.
time?
So, yeah, the cost issue is a big issue here. Right now, from what I see, maybe 10 to 15% of insurances are covering this medication. Now, I need to clarify, if you're diabetic, Ozempic or Mounjaro is applicable. Yeah, same medicine. And that can be readily prescribed to diabetics and for most people on insurance. However, if we're talking about only a weight loss focus, Wegovy and Zepbound, the coverage is limited, and then full out-of-pocket cost, if you don't have it on your company's formulary, so to speak, is about $1,000 a month. So that's really not affordable for people. And so there is an alternative, which is the compounded medicine, that is generally about a third that cost, and from my perspective, equally effective. But insurance coverage is a big issue, and even the compounded medication cost is prohibitive for some.
Yeah.
It's another reason I should mention, sometimes the cost is dose dependent. It's another reason that we'll talk about trying to keep the doses low.
Yeah. You were talking earlier about when we were offline, the sustainability and like whose responsibility is this, and how some insurance companies are starting to cover it, some are like stopping. So can you kind of walk us through just the
Yeah,
complicated uh, like atmosphere right now of coverage,
right.
because so many people, if they start covering it for weight loss, would qualify because, over 7 out of every 10 adults in America are overweight or obese. And
Yeah.
so who's bearing these costs?
So that's a great question. So the reason that insurance is slow to cover some of these medications is just, is it's an economic issue. There are companies that covered it early on that realized it was breaking the back in terms of their healthcare costs, and they couldn't do it. Not many Medicaid state Medicaid programs have covered it, but I heard North Carolina covered it, and they had to stop covering it because of the costs. There are some large employee systems that, again, have reversed coverage, and it's because $1,000 a month for 60 or 70% of your workforce is not sustainable. And then the whole issue of associated accountability comes in up in that. Who's going to pay for that? If somebody's paying, if insurance is covering that, do you have any responsibility in terms of doing the other things that you should be doing so you don't become dependent upon the medication lifelong? So things are going both ways. Some companies are dipping their toe into the water of providing coverage, sometimes requiring a comprehensive program if somebody's going to be on the medication, and other companies that backed off providing coverage. Interesting, Medicare covers people over 65 years of age. Has actually historically, this is interesting, been prohibited by Congress from covering obesity medications.
Hmm.
So that's why, for example, Zepbound and Wegovy now are not covered by Medicare. So if you're over 65, that's unavailable to you. Now, there's been a little chink in that armor in the last couple months where the drug companies are doing more studies to find more applicability for the drugs. And one thing they found was if for people that already have documented heart disease, it can reduce the risk of progression of heart disease. So Medicare did say, well, if you're overweight and you have heart disease, we'll look at covering that. But the indications and the coverage is just moving back and forth right
That's so interesting. And you're right. Like the Medicare in and of itself is not sustainable. I mean, I'm a physical therapist, and when I was practicing regular, that conversation was coming up all the time about Medicare slashing coverage for PTs and PTAs and
now.
reduced visits and all that stuff. And I'm really, really glad to be outside of the insurance system so that I can just provide the care that believe that people need. So
Yes.
that's really interesting. Thank you for bringing up those points. Now, you've mentioned the importance of low dose several times, and
Yeah.
I would love for you to describe what is technically, in your mind, a low dose of semaglutide or a comparable medication
Yeah.
compared to a high dose, so that if somebody is looking to take this medication or they're on this medication, they can check their prescription and say, well, I'm on a high dose. Should I switch to a low dose? And if so, what should I ask for there?
So let's talk about the way these medications are prescribed, so I can answer that question. So as you probably know, you start at a low dose, and the dose is titrated up over a period of months. So it's moved up, and the reason for that is because of the side effect profile. These medications routinely cause nausea. I would say in the majority of patients, there is some risk of nausea. There is, of course, a laundry list of other potential side effects and complications. I think if you use the medications prudently, which is in low doses, you don't see a lot of that, and I haven't seen a lot of that. But nausea is common. But you got to titrate it up, and let's talk about semaglutide numbers to begin with. You start at 0.25. This is Ozempic and Wegovy, same thing. You start at 0.25 milligrams a month, and a week, and you take it weekly for a month, and then after your body accommodates to that. Usually by the third or fourth dose, you aren't getting any nausea anymore, and you pop it up, and that pattern may recur, and you get more nausea. So when I use these medications, I usually go through that progression up to a ceiling dose of about 1.5 milligrams. So pretty much everybody starts at 0.25, go to zero point 0.5, go to 1, go to 1.5. Now, Wegovy can go up to 2.4 milligrams. Again, we'll get to this conversation, but I think that creates greater dependence because, the longer the journey up, the harder the journey back down. And so I think it's prudent to keep this at moderate doses. And my experience is that if people are doing the other things that they should be doing, the low carb, the intermittent fasting, strength training, which is essential when you're on these medications, then you can cap those doses. You don't have to go to high doses. But again, for somebody that, I mean, for people that maybe just want to take a shot. And I don't think people really just want to take a shot, but sometimes they're being pushed in that direction by providers without correct support services. That then you can go up to those high doses and get stuck there. So my use of this medicine is again at lower doses over a period of time. And you were talking, you and I were talking beforehand. The genie is out of the bottle. People are going to use these medications. I have people that contact me and they are very focused on using the medications, and I'll say, let's look at that, but stop. Let's think again what the end's going to look like. How are we going to get you where you want to be, and how are you going to sustain that weight loss for a lifetime after you're off the medication? But I would think of a good soothing dose in the range of 1.5 milligrams as opposed to 2.4 milligrams. For people that are on Mounjaro or Zepbound, the milligrams are different, but the highest dose on Zepbound or Mounjaro is 15 milligrams. I like to keep people, under 10, usually at 7.5.
Okay, that's so helpful. I really hope people are valuing this conversation as much as I am. I know I'm learning a ton. And you said that one of the risks of taking these medications at a higher doses is dependency. Now, are you talking about physical dependency, like, alcohol or a drug substance, or are you talking psychological dependency? Can you go into that a little bit more?
Yeah, it's more psychological dependency. You don't have withdrawal symptoms if you go off these medications. But the issue is weight regain.
Mhm.
60% of the weight lost is regained unless there is a great focus on continuing lifestyle changes as you titrate down and off the medication. So there is not physical dependence, but you start titrating down. If you aren't doing the other things, the weight is going to come back on, and you're going to become psychologically dependent on it, which is a bad place to be if either you're regaining weight, or you feel, oh, I can't go off medication because I'll go back to the way I was. And that's why the whole lifestyle approach is so critical. I mean, you want to be on this medication for a period of months, not for years or a lifetime. And so if you decide to go this direction, you need to go into this with your eyes open.
Mhm. Now, I had a question. You said that there's no withdrawal symptoms from going off of these medications. Have you experienced like rebound eating or increased
Well,
appetite above their baseline when they stop
yeah.
these medications?
Yes, I didn't consider that a withdrawal symptoms, but the
Yeah.
term that I hear over and over again is food noise. The
Mhm.
food noise comes back.
Yeah.
Yeah, so that is, but again, I think that's more psychological issue than, and what I meant to speak to, and I didn't clarify,
It's okay.
is actually a physical illness as a result of withdrawals.
No, I would agree with you. I wouldn't classify that as a withdrawal either, but kind of a side effect maybe of withdrawal.
Yeah,
What do you recommend people do? So let's kind of talk about some of those side effects. You mentioned most people have nausea. Most people have some degree of muscle loss. And then the food noise, like that quiets when they're on the medication that might rise up again when they're off. What are some
yeah.
suggestions that you have for the nausea? Let's start there.
Well, the best approach is a slow titration up.
Okay.
To keep the doses low. You're going to have less nausea at a milligram than you do at 2.4 milligrams. So, and this is facilitating your effort to eventually get off the medication anyways. So keep the doses low. Medications could be used, the common one for nausea is Zofran, but it should be used in a limited manner, because if somebody is having so much nausea that they need Zofran every dose, then that's probably not a good medication for them.
Okay.
So really the approach is to titrate it up very slowly. I would like to mention that I don't think anybody should go on the medication before they have an initial complete um, examination. So in my mind, and again, this is something I've been doing for years. It includes a metabolic health assessment, which includes an assessment of insulin resistance. And I know that you know all about this, checking fasting insulin levels, calculating a level of insulin resistance. I, of course, am a big advocate of the continuous glucose monitors. I like to have people wear a CGM for a couple weeks as part of that initial assessment before we even talk about medications. And my preference is, though, I have people, as you and I have talked, I have people come to me and they're focused on medications right out of the gate. And if, they do the other things that we need to do to eventually get them off the medication, I will agree to do that. But my preference is to do this full metabolic health evaluation, use CGMs to guide a low carb diet, and then when you hit a stall, maybe begin to lean on the medicines in limited doses.
Mm. Okay, there's so many follow-up questions that I have, so many directions that I want to go. But let's stick with the side effects first, and then we'll kind of keep going down my list.
Okay.
So,
All right.
how about muscle loss? When we're on these medications, why is muscle loss so common, and how do we mitigate that?
So when you lose weight, no matter what the avenue of you losing weight is, you're going to have some muscle mass loss. Okay. These medications seem to have a differential increase in muscle mass loss. Anybody that's on these medications, anybody should be strength training. You should not be on these medications without strength training to maintain muscle mass. We all, as I don't have to tell you this, but we all are losing muscle mass as we age. What is it, 7% or more a decade? Um, yeah, do I have the numbers close
I
to being
don't know.
right?
It
Yeah,
it
yeah,
depends on your age and your decade, but yeah,
yeah.
a significant amount per decade.
Yeah, I mean, I can to tell, we all know that from our workouts as we age, that we're losing some muscle mass. And so you got to keep focused on the muscle mass and the protein. We're swimming upstream because we're losing muscle mass as we age. And for the women, men too. I mean, men have osteoporosis too, but
Mhm.
for the women especially because they're more subject to osteoporosis, you got to be strength training because the strength of your bones relates to your muscle mass size. If you have a bigger muscle mass and you're putting a little bit more strain on your bones with that muscle mass working out, then the bones react by getting stronger.
Yep, and I
So yeah,
sorry.
you got to be straight. If people walk away with one recollection from this discussion, it needs to be: if I'm on these medicines, I got to be strength training and I got to be getting adequate protein.
Yep, and for people who need a resource for that, I'm gonna do a shameless plug here. We have a
Okay.
YouTube playlist of strength training for beginners. There's a really good introductory video where people can watch to see how do I start strength training, how do I reduce my risk of injury, and then over 30 tutorial videos with upper body, core, and lower body. It's all free on YouTube. You can go check it out with me explaining certain strength, like basic strength training movements, how to make them easier, harder, etc, because I'm a firm believer that everybody needs access to that information on how to start strength training and do it safely. So, thank you for that. I completely agree. I think that that's a really important point to make, that with these medications, it seems like we're losing more muscle mass than if we were just following a low carb diet or whatever dietary approach you want to follow to
Right.
lose weight. I had another question here on the side effects, which was the food noise. So that was the
Yeah.
other side effects when when they stop the medications, the food noise returns. That's more of a psychological effect. So what do you
Right.
recommend to your patients on how to deal with that?
So as you know, I'm a low carb person.
Mhm.
Having studied this for years, I came to this through the emergency department when I realized, what gets all the press in the emergency department is the overdoses and the multiple traumas and the gunshot wounds. But what we see day in and day out every day is metabolic disease and the vascular complications, mostly from high blood sugar, and then musculoskeletal complications from obesity. And so I believe that a low carb diet really is the way to go with this. So I think low carb is a lifestyle change. And I personally has experienced that, and vast majority of my patients have, and it doesn't happen overnight. But you cut out food noise. I mean, you cut out thoughts of pizza and donuts and ice cream, and it gets to the point where it doesn't even become a consideration. It's not even in your mind anymore.
Well,
And so I think that is the best approach. If there's medications that are going to be used temporarily, to cut out the food noise is just, embrace a low carb lifestyle. Different, we haven't talked in detail about this, but, I know you believe in reducing insulin resistance. I think a low carb intermittent fasting approach is the best way to reduce insulin resistance. And I believe that lifestyle is much more sustainable than a calories in, calories out approach where you're just trying to, do an energy balance thing. Low carb is the lifestyle, and if you embrace that, preferably before and then while you're on these medications and after you're off these medications, you're going to have much more success dealing with that food noise.
100%. I can testify to that, changing my own lifestyle. And a lot of patients, members, Zivley members have also adopted that lower carb intermittent fasting lifestyle. It has to be a lifestyle. So let me ask you this. If the end game is to get off of these medications and we're beginning with the end in mind, why start them in the first place?
So that's a great question. So I initially try to avoid starting them, and I'll just speak very frankly to this. If I have somebody come to me because they've heard that we've had success with patients and they are focused on medication, then I will agree to do that along with the other things as we talked about, because I don't want to lose them to an internet program where they aren't going to get the support and they aren't going to hear the advocacy related to the lifestyle changes.
Yep.
So I'll use the medications in two instances, and it's for a minority of my patients that I use the medications. And one is if somebody is absolutely focused, and I this may be a bad thing, but if they decide they're going to go somewhere else where they aren't going to get support, then I'd rather get them in the tent. I'd rather get them in the fold where they're going to hear about the right way to do it.
Mm-hmm.
And then the other time is even with, low carb intermittent fasting and strength training, people can get frustrated when they go through periods of stalls.
Mm-hmm.
You can have somebody that wants to lose 90 pounds and they can do great losing 40 pounds, and then they hit a stall and they can get frustrated. And we'll dip our toe in the water of the medications during that period as well. So that's generally the two instances where I will use the medicine. But again, it's always limited doses and time limited as well.
Limited duration. Yeah. Because in my mind, I'm working with a client right now and at a weight loss stall. And whenever I get to my own, intermittent fasting is my go-to. Like
Yeah.
that usually, and mixing up the fasting schedule, maybe doing an extended fast, that kind of stuff. So
Yeah.
that just kind of came to my mind as we were talking, like, okay, if we're beginning with the end in mind. But I think the perfect thing that you said is for some patients, it's a door in. They want that medication, they're going to get it somewhere. I might as well give it to them so that I can provide the support needed to keep the weight
Right.
off, and so that I can reduce the psychological dependence that they might get if they're getting it on the internet at a dose that's not appropriate for them. All those things are so good to see, so good to hear you say. So we kind of touched on this, but I also wanted to dig in just a little bit more. The question that I had was, what criteria do you use to determine if someone is a good candidate for these medications versus just lifestyle changes? And it sounds like you want people to do the lifestyle changes, but if they really want the medications, then you'll consider it for them. But what if somebody is like, they have uncontrolled diabetes or they have extreme obesity? Those are the other two types of situations
Right.
where I've heard physicians being more open to prescribing these. What's your thoughts on those two? Or are those not really the types of patients that you see in your practice?
Well, I do see those types of patients in my practice. For diabetes, for blood sugar control, these medications I feel are appropriate. I still think, though, they should be used in the context of, while you're controlling your blood sugar, let's do the other things you can do to control your blood sugar.
Okay.
Again, low carb, intermittent fasting, which I got to say, intermittent fasting gets embraced as a lifestyle just like low carb does. And once you've done it for a while, you don't really even think about it. I'm sure that, your listeners, many of your listeners have embraced that.
None.
But so with diabetics, it's appropriate. And then the other category is, I think there is a very obese category, a BMI of 35 or higher, where they really have, and a lot of times those people, especially if they're middle-aged or older, will have some musculoskeletal issues as
Yeah.
well. And I think trying to get them to a weight where they can then increase activity is a good thing. Because sometimes they can't work out.
Mhm.
A lot of that I think has to do, we haven't talked about this, but if your blood sugar is high for a long period of time, you're getting that, inflammation of your cartilage and inflammation of your joints. So
Yep.
the use of these medications to help control that blood sugar, to maybe initially decrease weight, decrease joint inflammation, and get people moving, I think is a consideration as well.
I just want to highlight something that you said. You use these medications minimally in your practice. You focus so much on the lifestyle changes, which is all we do at Ziply. And what advice would you give to somebody who's maybe in their mid to late 30s, early 40s? They have, 30, 40, maybe like up to 50 pounds ish to lose, and they want to take the medication, but you see them not making the lifestyle changes. You see them eating junk. You see them drinking alcohol in excess. You see them not working out. What do you tell that person?
Yeah, so fortunately, my patient population is self-selected. People come to me because they want to make changes. And we talk about, those changes you have to make before we talk about medicine. And for 5 years, I did this without medications, and,
Mhm.
would have people lose, 60, 70, 100 pounds just with low carb, guided by continuous glucose monitors, intermittent fasting, and strength training.
Mhm.
So what we really want to do is start with the lifestyle changes. So people come and they're completely focused on medication. It's like, step back. Let's do a metabolic health evaluation. Let's find out exactly where you are. Let's start talk about the lifestyle changes, and just if you need the medicine at some point, we can talk about that. But let's see what you can do without it. And then I think people have a foundational understanding of the lifestyle changes that are going to be necessary for them to eventually get off the medication. And the other argument is, maybe people, this is what the pharmaceutical companies want, and maybe some providers is just like, oh, we're just going to give you the medicine, you're going to be on it for the rest of your life. I don't have patients come to me with that attitude. The people that come to me are interested in the foundational changes that will allow them to use the medication as a crutch. Crutches don't necessarily have to be bad. If I sprain my ankle and I need to use a crutch, for a couple weeks, then I can do that. But the plan is not to be dependent upon the crutch for the
Right.
rest of my life.
Eventually, you want your foot to get better. Eventually, you want your metabolism to get better, your lifestyle habits to get better, and then not need the crutch in the first place. All right.
Right.
So I have a couple other questions about, you've mentioned low carb, intermittent fasting, CGM, and I'm a huge advocate of all of those things. And I just kind of wanted to pick your brain on your philosophy with things. So so typically, like what I recommend, let's learn how to eat first. Like, let's learn how to fuel your body with the right amount of protein, carbs, fats, and then maybe fast like 12 to 14 hours a day
Exactly.
before you progress your intermittent fasting. What's your philosophy on that?
So again, the first thing I like to do is do an evaluation with the CGM. You told me I could make a plug for the book at some point, so I'm going
Yes,
to use this
anytime.
opportunity.
Yes.
Okay, so this is the book, The Continuous Glucose Monitor Revolution for Non-Diabetics. CGMs, of course, were made for diabetics to dose insulin, but unbelievable tools in educating people about their blood glucose physiology.
Mhm.
So I have people come in, and the first thing we do is a full evaluation, where they wear a CGM for 2 weeks. We check a fasting insulin level. We get all the data. We consider their cholesterol, etc. And then the place to start, which I think was your question, is okay, based on that data that we've collected over a couple weeks, what's the program going to be? What is the macronutrient mix going to look like? What's going to be the carb limit? How much protein are you going to need? You've never strength trained before? Well, let's talk about what a half hour 3 times a week to start with bands looks like. or, get a couple 5 or 7 pound weights at home you can look at. Let's talk about what the fasting period is. You've never fasted. Well, okay, let's just do 10 hours overnight to begin with. And then we'll look at, getting you to 12 and 14 and maybe 16. So I think the beginning is a full evaluation. Once you're on the medicine, the CGM data isn't going to be as accurate, because your blood sugar is going to
That's
be
such a
brought
good
down.
point. Such a good
Yeah.
point.
So I had a number of new patients this week, and it's like, let's get you a CGM. They came to me wanting to talk about medicine. It's like, let's do a CGM evaluation first. Let's find out what your fasting insulin level is, because if we just start you on medicine, then your numbers are going to be distorted, and you really aren't going to understand your natural state and where you live to begin. In fact, when I use the CGMs in the first few weeks, I ask people not to change their diet, because I want them to see, what maybe the largely processed food diet they've been eating has been doing to their blood sugar physiology. And then after that 2 weeks, we of course got plenty of time to correct that diet. So you start by gathering data, and then, in summary, it's like, a diagnostic period of time, gather data, okay, put a therapeutic plan together, and then institute that therapeutic plan. And I use CGMs to help guide diets as well, long term. Some people want to use them constantly, some people want to use them intermittently. And then after that, if there's a consideration of maybe needing medicine at some point, we'll do that. So I think that's the best progression.
Love it. Love everything you just said. It's so hard when you're wearing a continuous glucose monitor to not change what you're eating.
It is.
It's really
Yeah.
good data to help you reduce your carb intake. But I agree that it's helpful to eat that so that you get that immediate feedback about what those foods do to your glucose levels, because otherwise,
Yeah.
the effects of a high carb diet, of a processed food diet, you're not going to see those for decades. So I think the beautiful thing of a CGM is it brings the consequences into the present moment. And I think
Yeah.
that's very motivating for people to change their habits. Now, you mentioned that you use the CGM to help guide the dietary recommendations. Can you give us some specific parameters or information that you look at on somebody's CGM when
Yeah.
determining, say, like their personal carbohydrate tolerance or threshold?
Right. I'm going to tell you, it's very individualized,
Okay.
because I have people that come in and they might have spikes that are, they only go to 140 or so. This is spikes, elevations in blood glucose after ingestion of a meal or carbs. And I have a lot of people that come in to me, and they just, the goal is, I need to lose 40 pounds. And you put a CGM on them, and they're spiking their sugars to 240. They in fact, have blown through the pre-diabetic phase without even knowing it,
Hmm.
and are diabetic. And so it's variable. So what I would say is, it's kind of like a progression of goal setting. Meaning, if somebody comes in and they're spiking to 180, it's like, okay, let's try and keep your spikes for the next month under 150.
Gotcha.
The other number we look at is averages. If your average for that person is 110, it's like, let's get your averages under 100 for the next month. And then once they incrementally reach that goal, we set a more rigorous goal. But during this time, they're learning. They're learning about low carb. They're learning about intermittent fasting. They're integrating strength training to decrease insulin resistance. I got to just plug here, strength training is, you're an advocate of it, but one of the reasons I love strength training is because the majority of Americans are overweight because of insulin resistance. And if you could increase the size of your muscles, you're increasing the quality and the receptivity of those insulin receptors on your muscles. Your muscles are soaking up more insulin, soaking up more blood glucose, reversing your insulin resistance. So I'm not anti-cardiovascular training. It's like, if you need to get on the treadmill or the bike, that's okay. But I actually try and have people meet the American Heart Association criteria for cardiovascular training. If you do that rigorously, you can do it in 75 minutes a week, meeting that criteria. And then, because we all have limited time, let's spend that extra time. Let's spend the majority of the workout time on strength training.
Mm-hmm. You're speaking my language here. Okay. So one issue with CGM is cost. And I believe that Dexcom is coming out with a
Yeah.
CGM that people can get in the States, because I think in Europe and I know in Canada, people can already
Yeah.
get a CGM over the counter. But
Right.
what are some tips that you have for people to reduce the out-of-pocket expense to get a continuous glucose monitor?
So just a little insight into this for you looking for. First of all, you got to find a practitioner for now because they have to be prescribed that believes in it. I have patients that have asked their doctor. I said, "You're not diabetic.
I
You don't
know,
need
it's
it."
sad.
So
Yes.
yeah, sometimes insurance company criteria is you not only have to be diabetic, but you got to be on insulin in order to get it. But I have a tendency to use the freestyle habits. There is a coupon generally available that providers can utilize to get the first one free. So you can get a 2-week CGM generally the first time at no cost. And what I found, which is interesting, is that even if you aren't diabetic, for most privately insured people, insurance can be applied and generally cut the cost in half. So the straight out of pocket cost for CGMs generally around $70 or $75.
Mm.
What I found is patients run it through their insurance, even if they aren't diabetic, if they just have insurance, generally it's around $35 or so. Generally Medicare or Medicaid again are not friendly to helping that patient population get those.
Yeah.
But you can cut the cost by running it through insurance, and they are going over the counter, and that's a great thing. But I actually have heard that they're going to be about $90
I
for
was
two
assuming.
weeks.
I know. I was like,
Yeah,
"Yeah, they're gonna sell it over the counter for a big profit," and what I
yeah,
did was I asked my doctor to write one, and she did, and then we don't have insurance, so both my husband and I, or me, however you say that, we're self-employed, and
yeah,
so we use Samaritan, which is a Christian cost sharings program,
yeah,
and what we did was that my physician called it into the Hy-Vee pharmacy. I'm assuming that this would work at Walgreens or CVS or wherever. And then each pharmacy usually has a discount card that they can run prescriptions
right,
through. I'm just
yeah.
not sure if you can only use that discount card if you don't have insurance. So I always ask the pharmacy, "Hey, run that through your discount card or maybe see if GoodRx
Yeah.
has a coupon." But I got one for $20 for a
Oh,
2-week
that's great.
CGM. Yeah, so I
Yeah.
didn't know if you had any other tips, but all of those
No, insure
great.
yeah, actually, the discount cards sometimes work even if you have insurance. So
Okay,
you just gotta work with the pharmacist to explore, is it cheaper through my insurance, or should I use a GoodRx or other card or whatever? But yeah, if approach that in a manner to just try and find the best deal, generally, you can save some.
yeah, awesome. Okay, well, I know that you have a book that you wrote about this. Before we get to that and kind of what's in the book, is there anything else that you think is really pertinent to add to this conversation about semaglutide or CGMs or appropriate use of semaglutide?
Yeah, I think it's really what we've talked about, but to summarize, again, it's begin with the end in mind. If you're going to use the medications, make sure you're doing the other things that are going to sustain your metabolic health for a lifetime. I just, very strongly believe that the tools we've talked about, again, low carb, intermittent fasting, strength training, are critical. Historically, I think, you look back at pictures in movies, photographs and movies in the 40s and 50s, you didn't see obese people then. And, the food pyramid came in and we were instantly told to increase our carbs in our diet 25%. We replaced fat because cholesterol became public enemy number one. We replaced fat with carbs, and then the obesity epidemic took off, and the diabetic epidemic took off. And really, when you're talking about low carb intermittent fasting, you're really just going back to the way Americans ate for generations before we were told to follow the food pyramid. And of course, the food pyramid came in, food processing industry jumped on board because there's nothing that's more profitable than combined sugar, refined grains, and seed oils. And they have a long shelf life. And then the pharmaceutical industry joined in, saying, if your cholesterol goes up, we got a medicine to treat that. And then unfortunately, I'm just to say medicine has changed too. When I was getting out of my residency, a lot of docs were still in private practice. And
Mhm.
docs now, and I got a lot of friends that are primary care docs. They know I'm saying this,
Well,
but they're relegated. They're largely working for health systems or sometimes even, large public companies. and they're relegated to 20 minutes with their patients. And in that period of time, you don't have time to talk about the things we're talking about here today or implement that kind of plan. You have time to adjust blood pressure medication, or maybe add a new diabetic medication. You're just trying to, it's like whack-a-mole. We're just trying to, stave off the disease. So, I guess globally, I'm kind of rambling here, but globally, I would ask people to find somebody to work with like you or like me, that can help them talk about preventing and reversing disease rather than just treating it.
Awesome. Oh man, this honestly has been one of my favorite interviews that I've ever done. I think this information is
Okay.
so pertinent and important to get out in this season where these medications, I believe, are being overprescribed or prescribed inappropriately. And I think that I hope people are listening to this conversation. If you liked this conversation, subscribe to the channel, subscribe to the podcast, give it a thumbs up, leave a comment, share it with a friend. People need to know this information. And I know that you're so passionate about this that you wrote a book, which is a huge accomplishment. Congratulations on that. Can you let us know kind of what people can learn in your book and where they can get that?
Yeah, it's really what we've talked about. Thank you for allowing me to mention it again. Again, it's the Continuous Glucose Monitor Revolution. It's the best-selling book on Amazon on CGMs. Again, for non-diabetics, pre-diabetics, and non-diabetics to get a good handle on your blood glucose physiology. And then I'm also going to mention for people that are looking for a doc to work with, either independent of the medications or with low-dose, time-limited medications. My practice is primarily a telemedicine practice, and I'm licensed in Ohio, Indiana, Florida, and Arizona. And my website is Metabolic MDs, just the word metabolic, and MDS.com.
Oh my
I
God.
appreciate you
Yeah,
letting me mention.
thank you. Of course. No, I think you're awesome. I knew right when I got the email for you to come on the podcast, I'm like, he's a good fit. We've got to have him on. This is the exact conversation that I've been wanting to have with somebody. And I'm so grateful that you shared your time and expertise with us today.
And I'm very grateful for having that opportunity, because the more people we can reach, the more lives we can change.
Yes, awesome. Well, thank you so much and best of luck to you.
All right. Thanks a lot, Morgan.